Hemato. Hemato is a condition wherein there is a contracture of the proximal interphalangeal joints, usually in the second toe, but sometimes in the third toe. It is extended at the metacarpophalangeal joint, flexed at the proximal interphalangeal joint, and extended at the distal interphalangeal joint. Epidemiology. Incidence. Most common deformity of lesser toes. Demographics. Most common in older women. Anatomic location. Second toes usually affected. Types. There are two types of hemato. First, flexible hematos. If the toes can still be moved at the joint, it's flexible hemato. This is good because this is an earlier, milder form of the problem. There may be several treatment options. Second, rigid hemato. If the tendons in the toe become rigid, they press the joint out of alignment. At this stage, the toes can't be moved. It usually has surgery as the treatment option. Anatomy. Deformities of the lesser digits result from an imbalance between the weak intrinsic muscles and stronger extrinsic muscles. Any imbalance in these forces will favor the stronger extrinsic muscles and thus will result in an extended proximal phalange and possible MTPJ hyperextension, as well as with a PIPJ and or DIPJ flexion due to the long unopposed flexion. Extensor digitorum longus (EDL). Primary function is in the swing phase of gait and functions to dorsiflex the foot. EDL tendon splits into four separate tendon slips as it courses across the ankle, with each one going to each of the lesser digits. Over the proximal phalanx, the tendon again divides into three slips, with the middle slip inserting into the base of the middle phalanx and the two lateral slips converting into a terminal tendon and inserting into the base of the distal phalanx. Extensor digitorum brevis has only three slips and insert into the fibrous expansion of EDL at the level of MTPJ of digit 2, 3, 4, forming what is called the extensor hood apparatus. Because of the unique anatomical construct, the pull of the EDL and EDB creates significant dorsiflex of the MTPJ and minimal dorsiflex power at the IPJ. Flexor digitorum longus divides into four separate slips that insert onto the lesser digits distal phalanx and flex the DIPJ, while FDB insert onto the middle phalanx and flexes the PIPJ. With no flexor inserting into the proximal phalanx, the working as an antagonist to the MPJ in an extended position, the force result in flexion in the PIP and DIP joints. MTPJ instability is commonly found in patients with digital deformities. The structures providing stability to this joint include the plantar plate along with the accessory and proper collateral ligaments at the lateral and medial aspect of the joint. If these key ligamentous structures attenuate or rupture, it will lead to instability at the level of MTPJ. Plantar plate ruptures may also lead to subluxation, and a collateral ligament injury may result in a medial or lateral drift with a potential valgus or varus rotation of the affected digit. This pathology leads to a crossover deformity. Risk factors. Certain risk factors increase likelihood of developing hemato, which includes: first, a family history of a hemato. Second, chronically wearing tight, pointy-toe shoes with small shoes which can force the ties into a dislocated position. This makes impossible for the muscle to stretch out. Third, having calluses, union, or cones, which are thickened layer of skins caused by prolonged and repeated friction. Toes deformity can also cause by muscle, nerve, or joint damage resulting from conditions such as osteoarthritis, rheumatoid arthritis, stroke, Charcot Marie Tooth disease, complex region pain syndrome, diabetes, Friedreich's ataxia, hallux valgus, pes planus. Symptoms and signs. Patient may feel pressure against the shoe and under the metatarsal head, particularly the second toe, which is often caused by retrograde pressure on the big toe. Patient complain of pain felt on the dorsal aspect of PIP joint. It is usually due to a core or callus that has developed. Once this happens, it is painful to wear regular shoes. Swelling or redness, inability to strengthen the toe, difficulty walking, a corn or callus on the top of the middle joint of the toe or on tip of the toe. Physical findings. Flexion deformity of the PIP joint or lesser toes is extension of DIP. Ankle plantar flexion. Flexion deformity corrects. Fixed deformity does not correct with ankle plantar flexion. Push-up test. Flexible deformity is reducible with dorsal directed pressure on the plantar aspect of the involved metatarsal. Effect of overactive intrinsic is removed. Diagnosis. To properly evaluate hematose, it is beneficial to retrieve diagnostic imaging. Radiograph. The anterior, posterior, oblique and lateral plane film radiographs are helpful in the evaluation of hematodeformities and should be taken with the patient being weight bearing. It may be used to assess contractures. Seeing into the medullary canal of the proximal phalanx is associated with hematodiformity and the sign is called gun barrel. Imaging makes it further possible to evaluate the relative metatarsal lengths, identifying hallus valgus as well as metatarsus adductus by examining the overall forefoot alignment. This is particularly helpful during a preoperative assessment. To determine the length of the hematome preoperatively, a transverse line may be drawn on the radiograph from the tip of the distal phalanx of the adjacent digit on either side. A long toe would overlap this line. Magnetic resonance image MRI. Magnetic resonance imaging series may be helpful in the event that there is a suspicion of a plantar plate rupture. This kind of advanced diagnostic imaging may further help detect soft tissue or osseous pathologies such as a vascular necrosis of the metatarsal head, with the second metatarsal being the most common affected, or defect of the cartilage. If the patient has a medical history with comorbidities such as diabetes, distal peripheral neuropathy, or peripheral vascular disease, non-invasive arterial studies may be warranted to assure healing assessment. Treatment. Non-operative. Shoes with high toe boxes, foam or silicone gel sleeves. Exercises. Specific exercises can help strengthen the muscle in the foot, gently stretching the toes manually or using toes to pick things up off the floor. Toe curls to strengthen the toes. Towel curl. Place a towel under the foot and use toes to crumple it. Over-the-counter remedies. Commercial available straps, cushions or non-medicated corn pads can help relieve pain. Surgical treatments. Flexor tendon to EDL tendon transfer. Indication. Flexible deformity that has failed non-operative management. PIP resection, arthroplasty, plus minus tenotomy and tendon transfer. Indication. Rigid deformity that has failed non-operative management. Griddle stone procedure with FDL to EDL transfer. Indication. MTP involvement. FDL to extensor transfer restores weight bearing of toe. EDLZ lengthening or tenotomy. Indication. Mild MTP hyperextension. EDL Z lengthening and dorsal capsular release. Indication moderate to severe MTP hyperextension. PIP joint arthrodesis. Indication an option in rigid deformity. Outcomes high non union rate. Veil osteotomy. This is a distal oblique osteotomy resulting in a shortening of the metatarsal and is a procedure most commonly seen when addressing hematose or claustose. It is often used to correct dislocation of the digit and angular deformities. Treat concurrent forefoot deformity. Correct hallus valgus orthodesis for severe hallus valgus touching third toe. Thank you.